Welcome to the first episode of Medic Pinoyz, brought to you by Pinoyz Studios.
On today's episode, we will be performing a proper trauma assessment for you, as well as how to manage a trauma patient.
And as paramedic students, we must not only learn how to assess the situation, but how to properly manage it.
In today's episode, we'll be reviewing how to manage a patient who's suffering from major hemorrhaging and a pericardic tamponade.
Alright, so let's begin with our scenario. So, you are dispatched to a 24-year-old male who is impaled by a wooden object 45 minutes ago. Let's arrive on scene.
Okay, we're here. Now before we get started, let's review a few key points about scene safety.
Before initiating contact with the patient, it is important for us to assess the scene and ensure there are no threats to our safety at the scene and that we are properly practicing body substance isolation. Considering the details provided to us from dispatch about our patient's impalement, we should approach the scene with caution and observe our surroundings for any dangers that may be present. We must also apply personal protective equipment to effectively protect ourselves from coming into contact with any harmful substances. We must also note the mechanism of injury and develop our own index of suspicion. Dispatch informed us that the patient's mechanism of injury was impalement by a wooden object, but from all the wounds that are covering the patient's body, it seems he experienced more than just impalement. I also need to note that he removed the impaled object before we arrived. Based on this information, it seems clear to me that I should be suspecting all sorts of multi-system trauma when I approach the patient. We should also consider spinal motion restriction precautions. Because it appears the patient has suffered from severe trauma, it would be a wise deduction to reduce spinal motion as much as possible to minimize the risk of inflicting further injury to the patient. We should also lastly consider requesting for extra support. In this scenario, we're further away from any trauma facilities and hospitals that are equipped to manage this patient's injuries. To increase the patient's chance of survival, we should request for additional support in consideration of the extent of his injuries and halo flight to provide quicker transport to a facility capable of caring for his injuries.
Now that we're here with our patient, we have to interview him while he's conscious. Let's try and get some information about the event from him. Sir, what happened here? Can you tell me what happened?
I don't really know what happened. I got stabbed, and I got beat up, and I pulled it out. I pulled out the
You
stick.
just pulled out the stick? You pulled it out.
Yes.
Sir! Oh man, he's unconscious now. Dude, where have you been?
Oh shoot, sorry, I jumped to the wrong scene. As I approach the patient, I notice he has pale, cool skin with wounds all over his body, and it appears he has lost and is continuing to lose copious amounts of blood. He is tachypneic. He has JVD and a sucking chest wound that needs to be immediately addressed. He is also suffering from syncopal episodes. As I assess his vitals, I notice he has a weak 30 pulse at a rate of 123. His respirations are labored and tachypneic, and he has a blood pressure of 108/72. The only information I have is that he was beaten senselessly and then stabbed in the chest. I did not have the chance to gather information on his medical background, but I need to manage his bleeding from multi-system trauma. All of this blood loss could eventually push the patient into a state of irreversible hypovolemic shock that would indefinitely eliminate his chances for survival if it is not promptly addressed. I need to consider giving TXA. Considering the normal process of the coagulation cascade, the progression of clotting occurs both extrinsically and intrinsically. The injuries and tissue trauma our patient suffered from stimulated the release of thromboplastin and activated proconvertin. The activated proconvertin then acts in tandem with thromboplastin and available calcium ions to activate Stewart factor. Stewart factor then interacts and activates Labile factor, effectively initiating fibrinolysis by converting prothrombin into thrombin to break down fibrinogen. When collagen is exposed to blood, Hageman factor is activated and interacts with plasma thromboplastin antecedent to initiate intrinsic coagulation. PTA then interacts with calcium and kininogen to activate Christmas factor. Christmas factor then stimulates the activation of anti-hemophilic factor A. Anti-hemophilic factor A then activates Stewart factor to stimulate labial factor and initiate fibrinolysis intrinsically as well. When tranexamic acid is administered to a patient, fibrinolysis is inhibited and plasminogen can no longer be converted into plasmin. In preventing this process of the coagulation cascade from occurring, the body's natural tendency to break down the fibrin that binds clots is negated, allowing for clots to be formed more immediately and effectively slow the major traumatic hemorrhaging. I need to administer 1 gram of TXA over 10 minutes through the IV we established. Now, we have observed a significant decrease in external hemorrhaging thanks to our use of tranexamic acid.
As I'm reassessing our patient, I've begun to notice a trend in a few symptoms he is displaying. Firstly, his vitals after my partner administered TXA have changed. His pulse is now 118 and his blood pressure has dropped to 63/46, indicating substantial hypotension and narrowing pulse pressure. I also note the presence of JVD and pulsus paradoxus. Although I cannot presently auscultate his heart tones, I can infer the presence of a pericardial tamponade and Beck's triad. The patient is entering irreversible shock, and TXA may have lowered his blood pressure even more drastically than the tamponade alone would have. I must consider performing an emergency pericardial centesis to assist the patient in regaining homeostasis. Now I'm going to gather my materials. First I have to grab an 18 gauge catheter, a 3-valve stopcock, a large syringe, alcohol or iodine, sterile gloves, and stabilizing materials. Now that I have my materials and I have my sterile gloves on, I'm going to palpate my puncture site in a subxiphoid manner, placing my hands just below the arch of the left side of the rib cage. Next, I'm going to clean the palpated site and insert the catheter at an angle no more than 45 degrees to attempt to enter the pericardial sac. I will continuously aspirate the syringe as I advance the needle so as to avoid puncturing the heart or one of the great vessels. And then I have to drain the pericardial sac as necessary and remove the catheter when the procedure is complete.
Welcome back.
That was quite the trip.
It indeed was. And so today we reviewed over how to properly assess and manage a patient. What else did we learn?
Well, after viewing today's episode, we learned how to manage our patient specifically and how to perform a pericardial centesis in an emergency situation.
And about that centesis, that skill is somewhat similar to the pleural decompression, right?
Yeah, and it's definitely not as invasive as like the needle cricothyrotomy. That's like insane.
And with that knowledge, I think paramedics should learn how to do a pericardial centesis.
We should be able to perform it on the field because, like in the video, during CPR, if we do know that the patient is presenting with symptoms of a tamponade, we should be able to respond in kind.
Yes, I agree. So, well, that ends today's episode.
Thank you for tuning in to this episode of Medic Pinoyz.